Hi everyone, my name is Jasmine. I'm a JCTC student in Louisville, Kentucky, and this is going to be a lecture on the immediate nursing, or miniature lecture, what did I say? On the immediate nursing actions right after a newborn baby is delivered. So let's first start off. Who is the main person that's going to do a lot of this? So initially, the person who's going to perform these tasks is the NICU nurse, and it's happening right there in the delivery room. As soon as the baby comes out, the NICU nurse is going to look for a few things. One of the things that NICU nurse is going to look at is the appearance of the child. The second thing the NICU nurse is going to look at is the status. And then she's going to look at the gestational age. Another thing that the nurse is going to look at is the vital signs and the measurement. So these are the core things that the NICU nurse is going to be looking for. Now, after the NICU nurse has determined that the baby is stable, then that baby will transfer to the labor and delivery nurse, who will then transfer into the postpartum area with the mom. Labor and delivery with the mom. The baby can be with the mom. Now, if a child has cardiac or respiratory problems, they're not going to transfer to labor and delivery postpartum area. Or, well, yes, postpartum area. So respiratory, what are we looking for in regards to respiratory problems with a newborn? The first thing we're going to look for is nasal flaring. Nasal flaring occurs because a child is trying to increase the surface area of their nose to intake more oxygen. The second thing that we're going to look at is retractions. Retractions are when you see the actual, so you can see the baby take a breath, and when a normal person takes a breath, like as I'm breathing, you can't see my ribs. But a retraction is when, for an infant, when you can actually see their ribs when they breathe in. Although they are diaphragmatic breathers initially, you should not see their ribs like that. Other things the nurse is looking for is abnormal breathing sounds, or the chest. Is the chest rising and falling appropriately? Does it look like this child is having a hard time? Another thing that can show either respiratory or cardiac is cyanosis. Is the baby blue? Now, acral cyanosis, which I'll get into later, is completely normal within that first 24-hour period. However, if it's past that 24-hour period, that is not normal. That can indicate a cyanotic heart defect and poor perfusion, okay? Other things that the nurse is going to look for is their body posture, okay? And normal newborns, especially when you look at the Ballard score, which is what the nurse will use to determine whether or not this baby is the appropriate neurologically and physiologically stable for the outside world. Let me make sure I said that right before I give you guys any weird information. Let me make sure I said that right. Okay, so I did say it right, thank God. Okay, so the Ballard score will then tell us neural and physical aspects that a child who is term or, and also the Ballard score can tell us if the mom is unsure of the baby's gestational age, and if we're unsure of it too. So when the baby comes out and we're assessing the baby, that can tell us if place that baby on a scale of where the baby should be, and if there's any problems that we can actually assist or do some type of intervention. But anyway, so cyanosis 2, and another thing, flaccid. Flaccid is a decreased muscle tone. Most babies, when they come out, they are extremely flexed. Okay, they are like cuddled in, and if you were to like pull their arm out, they would retract back, or they would do reflexes back. But well, that's what we're looking for too. So when the NICU nurse has the baby under the heat lamp with the sheet there to prevent them from having heat loss, we'll get into in a minute. Um, that's what she's looking for. Now, also the time frame. So for every 30 minutes, so let me write this down. So this is all the stuff we're looking for. Oh, and cardiac too. I almost forgot. Cardiac, what they're looking for in cardiac, the heart. You're looking for abnormal heart sounds. Heart sounds, okay? I'm going to get into this a little bit later, but murmurs are normal initially. However, after that first 24 to 48 period, they should not have murmurs anymore. And I'll get into that in a minute, because if they have a murmur, that can indicate some type of heart problem. Another thing that the nurse is going to do is do their measurements. Okay. They're going to measure them real quick, make sure they are good to go. Again, to that later on. But this video is just about immediate nursing care. So yeah. So next thing we're gonna talk about is the time frame. So the time frame. The NICU nurse is gonna do this every 30 minutes for the first 2 hours. Okay. She's gonna be taking that temperature. This temperature should be between 97.7 to 99. Okay. And I'm gonna get to the way to take it, but not right now. The respirations should be between 30 and 60. That heart rate should be between 110 to 160. Uh, and she's gonna do these things every 30 minutes. Okay. Thermoregulation. So the baby does not. I'm gonna get into this in more detail, but just for GPs, a baby does not know how to control or regulate their body temperature. They only have brown fat, and brown fat is used quickly based on how well the baby adapts outside the womb. But there are things that we can do to help prevent the baby from losing heat. We can swaddle the baby. We have a heat lamp. You want to make sure that you put something down on wherever you lay the sit or lay the baby at. You want to make sure that you dry the baby off immediately. You want to make sure there's no currents, no fans, no opening. But the four major things are evaporation, conduction, convection, and radiation. Get that in a little bit. All right, but these are for the time frames every 30 minutes for the first 2 hours. And then after the first 2 hours, then we're going to do every shift, like every 4 hours or per protocol. And then you're going to make sure that the mom and that baby have their ID matching. It usually is printed out before she gives birth, situational. But usually it is printed out. Look, at Norton, I know I saw them. They were already ready to go. And then they'll put that on there, and then they have security little alarms that set off if that baby moves from that floor. And only certain people are allowed to care for babies. Not everyone's allowed. We have a lot of baby snatchers. That does happen. People are crazy. And then we're gonna also give medications. Let me make sure I didn't miss anything. right, I forgot one more thing. So when when she is doing her assessment with respirations, okay, the bulb syringe. We have to make sure, as a nurse, if you're ever a NICU nurse, that you are doing the mouth and then the nose. In the HESI book, let me get it. This HESI book says, and the red HESI book, verified for both books, but this is the most updated one, 6th edition. It says that you have to do the mouth and then the nose, because if you do not do that and you do the nose and the mouth, that will irritate the baby, inflame the baby, and they are in risk for aspiration when you try to feed them. And that's when they get fluid into their lungs and they start choking. Then you have more problems because you have this baby who just came out, their lungs are just now trying to activate, and you just shove something down their nose, and they're obligatory nose breathers until they are 4 months old, so they do not have this capability to breathe out their mouth. And you just irritated it and inflamed it to where now they have more, it's causing them more, making their work of breathing harder. So we don't want to do that. And then you also want to make sure, I know in another instructor's video or teaching, she said you want to make sure that you make sure it's cleaned out, and make sure the mom takes that home with her. That thing collects germs. Make sure you clean it. Oh, medications. So, moving on. Yes. All right. So, medications. So, one of the first meds we're going to give them is erythromycin. Now, erythromycin is given to moms who have I can't spell. I can't spell today. Oh, I spell chlamydia. Horrible. All right. Oh gosh. Look. All right. Chlamydia. At least I know what drug, what disease this is. Chlamydia and gonorrhea. Now, they will give this to the mom. I probably spelled it wrong. I'm sorry. They will give this to the mom regardless of if she has chlamydia or gonorrhea. It just helps prevent against infections. Now, it is slightly blinding for the baby, but good news, they can't see that well, so, gotta weigh your options. And it is slightly irritating. And how do we do that? How do we put it on? You would move it from the inner to the outer, and you would like try to slightly open it, move it in and out, and make sure their eyes closed to get that medication running around. Another drug that we're gonna give them is vitamin K. Woohoo! It's just called aqua meflotin, also known as, I can't pronounce it, and I can barely spell it, phenotone neon, I think. Did I spell it right? Dang it. Phenotone neon, Datin, whatever. Oh God, I can't spell it. Save my life. Whatever. All right. So this one, did I spell that right? Nope. The devil's a liar. Mm-mm. Can't spell. All right. So vitamin K. These are the generic names for this. This is their brand name. So why would we give? Please forgive me if I can't spell or pronunciate these words right. All medical terms are hard. It's like a fifth-grade spelling bee. Anyway, why would we give a child vitamin K when they're born? We're going to give that child vitamin K. The parent can refuse it, I guess. It's their child. But I'm going to tell you the reason why we do give it is because it prevents blood clots. Their gut is sterile. They do not know how to have platelet formation. So the vitamin K will help them have coagulation. Okay, it's called the cascade, the platelet cascade. Okay, so giving them this will actually aid them forming blood clots. However, vitamin K will not work on hemophilia. There's some research on that. It will not help them. And we learned about hemophiliacs last exam, but just a refresher. Um, Mostly affects boys, XY, chromosome male. And how do we know that after we give them vitamin K, let's say we don't know, but there's other indications that, besides the vitamin K not working, that before we give it to them, that they have hemophilia. If they cut the cord and they're still bleeding, problem. Or let's say they go get a circumcision and they're not bleeding, problem. I mean, and they're still bleeding, problem. That could tell you that that child has hemophilia. And those are all the immediate nursing interventions for a child as soon as they come out the womb. So, respiratory, cardiac, APGAR, time frame, the temperature, the respirations, the heart rate, thermoregulation, ID band medications. One more thing I'm going to talk about is APGAR before I forget. So, an APGAR stands for appearance, pulse, grimace, tone, activity, which also means tone and respirations, right? So, what is APGAR? APGAR helps tell us how well they're adjusting outside the womb. Like Ballard score helps with predicting or showing us gestational age so we can care for that child properly. APGAR helps us determine if that child is adjusting well. APGAR, you can get in all 5 of these categories, these all stand for something. Is you can get a 0 or 1 or a 2. Max is 10 points, okay? And they would do this within, it's usually done the first to 5 minutes. So let's say the baby got a score of an 8, right? So on the paper, now keep in mind, we're documenting all this, okay? This is not something that we're just gonna, do and then document later. We never document later, we do it then. But let's say the score was an 8. We are going to write an 8, and then at what minute? 1. Initially, the NICU nurse is on point. They're looking at this baby so they come out, boom, looking for appearance, tone, color, respirations, heart rate, apical or heart rate at Erb's points. We're making sure they have pulses for 1 minute, respirations for 1 minute. We're looking at every single thing, okay? What's their color like? Are they flexed in, their hair, their fontanelles. There's a whole lot of stuff that NICU nurses are looking at initially to determine, is this child okay? Can this child survive when they go to labor and delivery? Yeah, so I think that's it for APGAR. And also, let me go over the score system real quick. If it is a 7 to 10, that means that child is great, okay? Like, for example, for the appearance portion, if they are a little slightly blue, like cyanosis, it's hard to tell initially. So they may get like a point off, because they're not pink. Um, you know, uh, but then, so 7 to 10, and then 4 to 6, which means that, they need like a little nursing intervention. Something is going on. Not too bad, but we can help it. Okay, if they're blue, if they're cold, we can give them heat, blankets, head covering, warm them up. Check again. With a 0 to 3, that means that they're going to need some type of resuscitation. And how do we know what type of care to provide if they need resuscitation? We're going to do an NRP. That is a neonatal resuscitation protocol. And that will tell us what we actually can do for that child based on how that child presents. There is no, we're just going to, and every NICU nurse is certified with this. It's like getting your CPR or something like that, or BLS or something like that. So they're going to know. And that's it for the immediate care of a child as soon as they leave the womb. The next video is going to be talking about general assessment portions. But I hope this helped my friends in nursing school. And I know this helps me to be able to verbally talk about this and video it and watch myself and hear myself talk about this. So I hope that you guys like my video, and I hope this helped every single last one of you. Bye.